Welcome to the Cardio Kidney Connections Progress in 2025. It's going to be an excellent session. Our first speaker for the day, the topic is going to be Advances in Management of Patients with Kidney Disease and Heart Failure by Dr. Daniel Edmonston. While he pulls up, let me briefly introduce him. He's an assistant professor of medicine in the Division of Nephrology at Duke University School of Medicine and a faculty member of the DCRI. His research topic focuses on clinical trials and epidemiological methods to mitigate cardiovascular complications of kidney disease and improve cardiovascular, kidney, and metabolic health.
Thank you so much. I want to start off by just generally thanking the NKF and the session organizers for the invitation to talk to you guys today, again, about heart failure and CKD co-management. I just wanted to pause and just acknowledge how exciting it is to be practicing medicine and nephrology right now at a time where we have such an explosion of medications and interest, and I think just the standing room only in this room is further evidence of just the excitement in this area. So I am privileged to be really a spokesperson for a lot of great work here done by others. These are my disclosures, but they're not going to be directly related to the topic that I'm talking about today. So the objectives for the talk today, I want to appreciate the overlapping burden of heart failure and kidney disease a bit and discuss some of the clinical implications of this overlap, and then pivot to a snapshot of our current guideline-directed medical therapies, or GDMT, as I'm going to refer to them moving forward, for heart failure and for CKD separately, and then cross the aisle a bit and see where there is data for safety and efficacy of heart failure GDMT in our patients with kidney disease, and then look at the implications, the heart failure implications of our CKD therapies that we prescribe to our patients as GDMT. Clearly, there are barriers to reaching target GDMT, especially as it pertains to heart failure GDMT in our patients with CKD, so we'll review some data on that and discuss some of those challenges. And then I want to touch on some of the emerging therapies, because excitingly, there are many on both sides of the aisle for both heart failure and CKD that will affect this axis, most positively, but some of which potentially negatively, but all of which will be important to discuss for today's talk. So I always like to start by just generally appreciating that there's an increase in prevalence of cardiovascular disease with advancing stages of kidney disease. But beyond just the increase in prevalence, there's an evolution in the phenotype of cardiovascular disease away from a predominantly atherosclerotic cardiovascular disease burden and towards diseases such as left ventricular hypertrophy, pulmonary hypertension, atrial fibrillation, other arrhythmias, and then heart failure, which become exceedingly prevalent in our patients with the most advanced stages of kidney disease. And this evolution of cardiovascular disease really mirrors an evolution of cardiovascular disease risk factors away from just traditional cardiovascular risk factors, which remain very prevalent and important in our patients, but they also have the accumulation of other risk factors more specific to their kidney disease: uremic factors, disordered minimal metabolism, anemia and iron deficiency, which we'll touch on as well, and of course, volume overload. These diseases are very entangled. People with kidney disease have a very high risk of developing heart failure. The presence of heart failure accelerates the development of kidney disease. And when these disease processes coexist, the mortality risk doubles compared to either alone. This is clearly an important and high-risk population. And this entanglement really reflects a lot of overlapping risk factors and pathophysiology. These disease processes share risks in terms of comorbidities such as diabetes and pathophysiological mechanisms such as fluid overload, sodium retention, adverse neurohormonal mechanisms such as RAS activation, inflammation, changes in bone mineral metabolism, anemia, and iron deficiency. So it's not surprising then that given the substantial amount of overlap in the pathophysiology and risk factors, that a lot of our guideline-directed medical therapies for heart failure and CKD will considerably overlap. And this is really a 30,000-foot view snapshot of the present consensus guideline recommendations for heart failure and CKD. both of which are somewhat separated in their recommendations for heart failure with reduced ejection fraction, or HFrEF, as I'll slip and say a few times, and heart failure with preserved ejection fraction, or HFpEF. And then, of course, on the CKD side, our recommendations are generally separated by the presence or absence of diabetes. So quickly moving through the recommendations for heart failure with preserved ejection fraction, there is a considerable amount of data demonstrating the cardiovascular and survival benefits for angiotensin-converting enzyme inhibitors and angiotensin receptor blockers. More recently, there has been direct superiority for this newer class of angiotensin receptor neprilysin inhibitors, or ARNIs, which, when directly compared to ACE inhibitors, were superior with regards to cardiovascular outcomes. And these have sort of become a first-line option in the place of ACE and ARBs when those are available. The counterintuitive data at first, but now has become dogma in heart failure of beta blockade, especially with long-acting metoprolol, bisoprolol, and carvedilol, are a mainstay of guideline-directed medical therapy for heart failure with preserved ejection fraction. Mineralocorticoid receptor antagonists, specifically talking about steroidal MRAs here, the best data for spironolactone and eplerenone. We will touch on some of the non-steroidal data in heart failure a little bit later in the talk, since that's sort of more emerging for heart failure guidelines specifically. And then, of course, recently we've had an explosion of data for SGLT2 inhibitors in heart failure with preserved ejection fraction, but also, very importantly, heart failure with preserved ejection fraction. For many, many years, heart failure with preserved ejection fraction, or HFpEF, was a model where moving the needle significantly for outcomes in these patients was just incredibly challenging. And that likely mirrored a lot of the challenges we experience in chronic kidney disease. This is a very heterogeneous population, and this probably reflects more of a syndrome than a very specific narrow pathophysiology and disease process. That being said, SGLT2 inhibitors with the EMPEROR Preserve trial and more recently DELIVER have demonstrated success in improving cardiovascular outcomes. A lower tier recommendation, but still recommended for this patient population in select cases, are steroidal MRAs and ARNI. Both the TOPCAT trial for MRAs and the Paragon trial for ARNIs failed to reach their primary outcome. Statistically a significant finding for the primary outcome. But importantly, there were strong suggestions for subgroup analyses, especially regional subgroup analyses for TOPCAT, and favorable trends towards efficacy that elevated both of these at least to a lower tier guideline recommendation in its population. For CKD, I won't belabor much of this, given the audience in this room very familiar with a lot of these trials, but it's important to at least appreciate the volume of work that went into these recommendations. There's the backbone of angiotensin-converting enzyme inhibitors and ARBs, improving outcomes predominantly in patients with albuminuric CKD, especially true for the trials for patients without diabetes. And then for decades, that was the only guideline-directed medical therapy we had for our patients with kidney disease until the emergence of the trials for SGLT2 inhibitors. These were initially suggested by the very successful cardiovascular outcomes trials in this population, EMPA-REG Outcome, the CANVAS trial network, demonstrating secondary outcomes showing kidney benefit, and then these were further confirmed in dedicated kidney outcomes trials with Credence, DAPA-CKD, and EMPA-Kidney. And importantly, this is also not just patients with diabetes and kidney disease. These findings have been extended to patients without diabetes, especially with the DAPA-CKD and EMPA-Kidney trials, as well as patients with lower and lower amounts, and in some cases no albuminuria, which is another important indication for SGLT2 inhibitors in this population. Recently, we've had data for non-steroidal MRAs, specifically finerenone, through the Fidelio DKD trial and the Fidelity pooled analyses of the Fidelio and Figaro trials, suggesting significant benefit in terms of kidney outcomes for patients with albuminuria and diabetes with CKD. And then most recently, I took the liberty to add GLP-1 receptor agonists to this list, even though it somewhat violated the structure I had for only pulling data from the guidelines that you see shown here, this data for the kidney guidelines from the 2024 KDIGO guidelines. The purpose here is that the reason for that is GLP-1 receptor agonists were already in the guidelines, but as a lower tier recommendation, as a highly recommended anti-glycemic agent after metformin and SGLT2 inhibitors because of their demonstrated cardiovascular improvements. But since we have publication now of the FLOW trial, specifically for semaglutide demonstrating a substantial kidney benefit in patients with CKD, it is really only a matter of time before this is formally elevated to the fourth pillar of GDMT for CKD. So with all of these exciting GDMT for heart failure for CKD, I wanted to take a little bit of time to look at the evidence for the heart failure GDMT and see how well and how safe they are and how well they perform and how safe they are in our patients with CKD. So to orient you just a little bit here, each column represents one of the pillars of GDMT for heart failure. First here for heart failure with reduced ejection fraction, and each row is a different level of CKD. The first of which being just the overall trial population. And really what I want you to appreciate from this is first, there is not a lot of robust data for our patients with advanced CKD, especially with GFR less than 30, with the pretty much lone exception of that being for SGLT2 inhibitor data coming from the EMPEROR Reduced trial. But overall, the major finding here is that for each of these classes of medications, there seems to be an relatively equal benefit in terms of heart failure outcomes for our patients with CKD. For heart failure with preserved ejection fraction, again, most of the data for advanced CKD is very limited with the exception of data down to an eGFR of 20 for the sister trial of EMPEROR Reduced, and that was EMPEROR Preserved. And we have data down to a GFR 25 for DELIVER. But generally for SGLT2 inhibitors, again, it shows persistent cardiovascular benefits in patients with chronic kidney disease. For the MRAs and for ARNI, the story is a little bit more interesting. As I mentioned earlier, neither landmark trial supporting both of these medications as GDMT for heart failure reached their primary endpoints, which is the reason why there's NS located by the risk reduction there to indicate that they were not significant. And there were no signal that there was any difference with the CKD subgroup for the TOPCAT trial. However, when you look at the data for ARNIs from the Paragon trial, Paragon heart failure trial, it is a little bit interesting that while the overall trial population had a non-significant 13% reduction, when you actually look at the CKD subgroup, which constituted about half of the trial cohort, there was a statistically significant benefit for the heart failure and CV death outcome in that population, at least suggestive enough to say that these are medications that are equally, if not more, efficacious in our patients with CKD. So let's take a step back and look at our GDMT for CKD and look at the heart failure outcomes from these therapies. Well, this is a little bit more straightforward. Each of these columns, again, is a GDMT for CKD, and I lumped all of these together since these are all CKD trials. And I think what's important to note here is that each of these have demonstrated heart failure benefit. The data for SGLT2 inhibitors, non-steroidal MRAs, GLP-1 receptor agonists are on a background of ACE and ARB, so they're additive benefits to existing ACE and ARB therapy. And each of these achieves statistically significant and clinically meaningful improvements in heart failure. I think this was all very well expected for our SGLT2 inhibitors and for, to some extent, for the non-steroidal MRA. This was, at least admittedly to me, a little bit surprising at the level of benefit that the FLOW trial demonstrated on the secondary analyses of that data for the heart failure reduction. Just given that the data from the cardiovascular outcomes trials previously would not have suggested such a strong heart failure benefit, but I was pleased to see that. And we presented, or published rather, data recently from a propensity score weighted analysis of people with type 2 diabetes in 82,000 patients, roughly, comparing initiation combination of SGLT2 inhibitors versus GLP-1 receptor agonist. And while we showed a suggestion for benefit in terms of edging out for SGLT2 inhibitors for kidney outcomes, there was really no difference that we could find between heart failure hospitalization and for MACE, which may further just support the cardiovascular benefit being at least on par with that shown in SGLT2 inhibitors. I think what's a more important way of looking at this data, though, is that, as I mentioned before, these latter three GDMTs are really standing on the shoulders of the previous of the standard therapy, which for each of these trials was ACE and ARBs. And if you look at it further, there was interesting data from a recent analysis published by Brendan Nguyen and colleagues in Circulation, where they modeled data from select clinical trials for each of these agents and used an actuarial method whereby you standardize by the participant's age and modeled the additive benefits for these outcomes, in this case heart failure, if you had a hypothetical patient who was able to start and achieve target doses of each of these therapies. And when you start to stack these therapies on top of one another, you start to appreciate the potential for a very exciting level of reduction in heart failure risk for a patient that can tolerate each of these GDMT. And I think another way that they successfully hammered this home is if you looked at a 50-year-old person who was able to start these 4 pillars of therapy versus just a baseline of ACE and ARB, you can expect over 3 years additional event-free survival from heart failure. So again, this is modeling data that was not direct clinical trial data for this additive effect. But even if it's just a fraction of this, it's a substantial amount of benefit if we can achieve full GDMT for our patients with CKD. And again, I wanted to look back at the heart failure GDMT and examine those which are not already recommended for CKD, just to see if there's data for kidney outcomes. And I'll go through this relatively briefly, but for ARNIs, again, we have data for heart failure with reduced ejection fraction, and this is from the Paradigm trial, and then data for the heart failure with preserved ejection fraction, which is the Paragon trial. I will summarize this by saying both trials had relatively few kidney events. They did look at kidney composite outcomes. It was not significant for the heart failure with reduced ejection fraction population. It was significant for the Paragon trial, the preserved ejection fraction. But I think what's a better way of viewing this is the eGFR data. There does seem to be a superior eGFR trend for patients in both cohorts that were treated with ARNI versus a background of either ACE inhibitor or ARB. In CKD, we don't have much trial data directly comparing in a similar manner ARNIs versus ARBs or ACE inhibitors. There was a trial published by Haynes and colleagues a few years ago that randomized about 414 patients with CKD for a year to ARNI versus ARB, and there was no difference in eGFR. But again, likely the small difference would need to be examined in a much larger trial follow-up with a longer follow-up. Briefly, for beta blockers, while there is reason to be excited about cardiovascular benefits of beta blockers in select groups with kidney disease, even advanced kidney disease, there's not really any solid data that suggests that the GFR trends for beta blockers are different. Steroidal MRAs, this one's a bit more interesting. So while we have the data for finerenone in CKD from the Figaro trial and the Fidelio trials, what we don't really have is quality evidence for the steroidal MRAs showing analogous kidney benefits. When you look at the heart failure trials for the steroidal MRAs, they also show this expected hemodynamic decline in GFR, as you see in both cases, the orange line there, but there's no recovery of GFR slope that we normally see in agents like SGLT2 inhibitors, which have a similar acute decline in eGFR for hemodynamic reasons. This separation of GFR just persists over the duration of time analyzed in these trials, which suggests that there's not a clear kidney benefit, at least in a heart failure-only population for the steroidal MRAs. We'll look at the finerenone data in just a minute. So, what are some of the challenges to getting GDMT for heart failure to our patients with kidney disease. There's compelling data that they're a benefit. There's compelling data that our patients with CKD will benefit. And there's data on top of that which suggests that perhaps they are the highest risk population. And so how well are we getting guideline-directed medical therapy to these patients, and what barriers are we encountering? Our colleagues in heart failure have had the fortune of being able to tackle this question of how to implement GDMT and how to initiate and best titrate these medications for many years before we have. And though they have multiple proposed approaches at doing this, many of them have consolidated on the principle of delivering all of four life-saving GDMT to all patients at risk to target doses with minimal delay. That is the general concept of most of these different approaches. And there is clinical trial evidence of investigating whether or not there are clinical benefits to implementing a very aggressive GDMT titration for patients admitted with acute decompensated heart failure versus a standard GDMT titration. And indeed, even after 180 days, there is a meaningful separation in cardiovascular outcomes. But as you would expect, they encountered issues that we're very familiar with. There was more AKI, there was more hyperkalemia in the group that was in the intensive titration for GDMT. However, I think there's a couple of things that are worth pointing out. One is the absolute incidence of these were relatively rare. And two, even though patients, as you would expect, with lower GFR achieved a lower optimal GDMT dose in this trial, the people with CKD that were randomized to the intensive group for GDMT escalation, titration rather, achieved a similar, if not nominally greater magnitude of benefit for the intensive GDMT strategy for the standard GDMT strategy. Yet we still have compelling amounts of data that show that our patients with kidney disease, even mild to moderate kidney disease, are reaching less and less target GDMT doses and prescriptions in heart failure. And what this really represents is a very classic risk treatment paradox, where our patients that are at the highest risk and would have the most potential benefit from these medications are the least likely to receive them. And so when thinking, one of the things I wanted to think through with this talk was, what do we do if we have patients with heart failure and kidney disease? If we view this as a competing indication, because we have GDMT for both diseases, there's some overlap, but there's some definitely distinct medications, not necessarily that would interfere with one another, but clearly there's a lot of challenge in getting patients to target doses. There are blood pressure issues, potassium issues that will limit titration. So how do we view people that have kidney disease and heart failure? Well, the first lens that I would view this from is one thing we have to stop doing when we think about CKD, GDMT for CKD, is viewing it solely for the purpose of slowing kidney disease progression. These are medications that have profound cardiovascular benefit that's present early and is very impactful. These are cardiovascular medications just as much as they are kidney medications. And so even if you're solely titrating to improvements in albuminuria or GFR and stopping titration of GDMT, we may be leaving a lot of cardiovascular benefit on the table. Second, at least nominally, if not clinically, there is more risk of cardiovascular disease in our patients with kidney disease. Patients are much more likely to die of cardiovascular disease than they are to progress to dialysis. And so when you have a patient with specifically heart failure with reduced ejection fraction and kidney disease, in my mind, for these reasons, it makes sense that the titration for heart failure with reserved ejection fraction should take precedence over initiation or titration through the lens purely of a CKD GDMT. For heart failure with preserved ejection fraction, I think it's a little bit, A, it's less of an issue, and B, it's less clear. First, the data for GDMT and heart failure with preserved ejection fraction is less compelling overall than it is for CKD. It's amazing that I can say that. But secondly, it's kind of a moot point because the data with the most efficacy in heart failure with preserved ejection fraction overlaps entirely with our treatment for CKD, specifically SGLT2 inhibitors, and it's not a titratable medication. So this is sort of a moot point. I think the only one area where this might impact our thinking about the order of operations for GDMT implementation from a CKD standpoint is whether or not this would be a patient population in whom initiating an SGLT2 inhibitor above, let's say, RAS inhibition, since there is not compelling evidence that RAS inhibition improves their heart failure outcomes versus SGLT2 inhibitors. And I think the most important takeaway from this is we need to avoid the bystander effect and limit risk treatment paradox. If you see a patient that has an indication for one of these GDMTs, either start them on it or facilitate them starting or titrating that medication. And in a lot of cases, this may not be you prescribing a heart failure medication to a heart failure patient, but it might be identifying that they could be on a higher dose or an additional medication, talking to the cardiologist and saying, what are your fears about going up or starting this medication? If they're potassium related, if they're GFR related, they're blood pressure related, we can help. We can be there to monitor and to at least guide more aggressive GDMT titration and take ownership and comfort of that as nephrologist. And in the last couple of minutes here, I wanted to just touch on some of the emerging GDMT, just to put it at the forefront of thought, because these are medications that are currently or very soon to be entering the guidelines. First, as I mentioned, there are medications for heart failure that are recommended that I didn't touch on as the pillars of GDMT, one of which is oral soluble guanylate cyclase stimulators. These are medications that actually have some nice data for mechanisms by which they can improve kidney outcomes, improve nitric oxide bioavailability, vascular inflammation, other things like that. And indeed, in heart failure with reserved ejection fraction, they do improve cardiovascular outcomes. The data, though, looking at kidney outcomes in this population is limited to just looking at the Victoria trial, which is the landmark trial in heart failure. And what this showed was really no big difference in EGFR creatinine for the Versuquat versus the standard care group. But I guess more importantly, when they did stratify the heart failure benefit by GFR, our patients with kidney disease still had benefit. As promised, there is very recent data for nonsteroidal MRAs in heart failure. This is recently published data from this past year for the Fine Arts trial, which is in heart failure with preserved or mildly reduced ejection fraction. And this demonstrated improvement in a composite of heart failure or CV death, not specifically CV death, but the composite did meet significance. But when they looked at the kidney composite outcome as a secondary outcome, as you can see, not only is there not compelling evidence of kidney benefit, there's a non-significant trend towards more kidney harm, if you will, with finerenone versus the comparator group. And I wanted to caveat this a little bit by saying, first of all, again, there was a very low event rate of kidney outcomes in this trial. So any relative difference here, albeit not significant, is really a very small absolute difference. This is a trial that's had a lot more concomitant SGLT2 inhibitor use than a lot of the other trials that we're used to seeing, especially these phase 3 trials. There's 13 to 14% SGLT2 at baseline and a lot more drop-in throughout the conduct of the trial as SGLT2 inhibitors became indicated for this population. The dose for finerenone, at least the maximum dose that the patients could achieve in the Fine Arts trial, is more than we see in our CKD trials. Specifically, the finerenone max dose here was 40 milligrams. For Figaro, it was 20 for patients with GFR over 60 and 10 for patients with a GFR less than 60, so a good bit different dose. And then in a very recently published secondary analysis, this kidney data, again, reaffirmed that there was no EGFR benefits, but there was a substantial reduction in UACR. So the jury's still out as to whether or not there is any appreciable kidney benefit for nonsteroidal MRAs in heart failure. IV iron repletion. Iron deficiency is definitely entangled with both CKD and heart failure. There are good trial data that repleting iron deficiency improves functional capacity in heart failure. The phase 3 trials of iron repletion in heart failure, shown here for the HEART-FID trial, which was published just a few years ago. There's not been convincing data that they improve hard clinical outcomes in heart failure, but this has the potential to be, I would say, even more consequential in CKD. Not to belabor the physiology here, but iron deficiency promotes transcription of fibroblast growth factor 23 or FGF23. It's a phosphaturic hormone that has potentially direct effects on the myocardium to induce left ventricular hypertrophy. It's clinically associated with heart failure. But when iron deficiency promotes the transcription of FGF23, it promotes a commensurate increase in the cleavage. So there's actually not an appreciable increase in biologically active FGF23. However, in CKD, it further increases the transcription of FGF23, but does not increase the cleavage by nearly as much. So this actually results, this combination results in quite a bit of an increase in biologically active FGF23. And the secondary, the meta-analysis rather of the heart failure trials for iron would suggest that perhaps in this CKD group, both dialysis and non-dialysis CKD, there is benefit for repleting iron deficiency in terms of heart failure outcomes. And then very briefly, since I'm running a little bit low on time, I wanted to touch on the endothelin receptor antagonist. The ASCEND trial of Avacentan, which was a mixed ERA versus placebo, was stopped early due to concerns of fluid overload and heart failure. The SONAR trial, published in 2019, evaluated atrasentan, which is more selective for the endothelin A receptor, thought to have less of the type B receptor-mediated fluid retention, and it was also a relatively lower dose. The end was included in enrichment period where patients had to demonstrate safety and efficacy prior to randomizing in the trial. This did demonstrate a very significant reduction in the kidney composite outcome, although there still was some signals towards fluid overload and adverse heart failure effects in this trial. But more recently, there's a very promising path forward, perhaps for ERAs, with some phase 2b data and some ongoing phase 3 trials, combining the ERAs with SGLT2 inhibitors to mitigate that fluid overload concern and still have pretty substantial and additive kidney benefits. And the last therapy that I wanted to mention are the aldosterone synthase inhibitors. So even maximal amount of GDMT implementation, we know there's still a residual risk for our patients. And one of the candidates for this residual risk is residual aldosterone. Even with MRA presence, aldosterone can still be present and act through non-genomic, non-MRA pathways to exert adverse cardiovascular and kidney effects. And aldosterone synthase inhibitors theoretically can mitigate that effect. Phase 2 trial evidence does show that there is, at least by way of reducing EGFR, some positive benefits for the combination of an ASI with an SGLT2 inhibitor versus SGLT2 inhibitor alone. Excitingly, there are phase 3 trials in heart failure and in CKD ongoing to further investigate this. So this is my summary here. Again, just appreciating the shared risk, pathophysiology, and understandably overlapping GDMT, the poor amount of uptake of heart failure GDMT in our patients with kidney disease, despite being at the highest risk, and the excitement for these emerging therapies, which are going to further entangle the heart failure and CKD axis and improve the health of our patients. Thank you.
We can take one question. We're right at 3 p.m. now, so to be fair to other speakers, if anyone has burning questions. I do have some questions on the poll, so I can pull up one of those if anyone has. Okay, so one question that was, the theme that has emerged is like, do you do these agents sequentially versus can you start it? Each of these agents could potentially cause an acute drop in GFR, which is not harmful. Yeah. However, if you do that combination therapy, if that drop, would it be harmful? So.
It's a great point. I will say if the current strategy in heart failure is usually is to start as many as you can and titrate later. Obviously in CKD with the GFR drop and the potassium risk, that's a little bit more challenging. We need implementation trials to actually look at the specific strategy of a more intensive GDMT. At the DCRI, we are launching an implementation trial that will, as part of one of the interventions using a pharmacist-guided management for GDMT versus standard care, will include an algorithm that I would consider to be an accelerated GDMT titration that would get someone from 0 to full GDMT in less than 6 months. And so we are hopeful to show some data that would secondarily demonstrate some of the safety that you're alluding to. How much GFR decline are we going to see and are comfortable with? But yeah, those are definitely prime for implementation trials to answer.
Excellent. Thank you.
Thank you.
Excellent. Our next speaker is Dr. Wolfgang Winkelmeyer. He's going to talk about treating patients with kidney disease and atrial fibrillation, what we have and what's in the pipeline. Dr. Winkelmeyer is the Gordon Kane Chair in Nephrology, Professor and Chief of Section of Nephrology at Baylor College of Medicine in Houston. He's a prolific clinical investigator with focus on the intersection between cardiovascular and kidney health. He has spent more than 15 years conducting NIH-funded research on the epidemiology of atrial fibrillation in persons with kidney failure on dialysis, as well as on the controversial question whether patients on dialysis who are diagnosed with atrial fibrillation should initiate oral anticoagulation. Dr. Winkelmeyer.
Thanks so much, Dr. Nathan. Heartfelt howdy to everybody. I doubt that I will be able to catch us up, but let's do our best here. Here are my disclosures. You can digest them briefly. And here are the learning objectives. Walking out of this room, I hope that you will appreciate the burden of atrial fibrillation, advanced chronic kidney disease, and those patients and populations with kidney failure, as well as to be able to appraise the existing literature on the evidence on the effectiveness and safety of vitamin K antagonist and direct target oral anticoagulants in advanced CKD and kidney failure. And finally, I would like you to understand the potential advantage and promise of factor 11A inhibitors, and their particular appeal for treating patients with advanced chronic kidney disease and kidney failure. So kidney disease and atrial fibrillation is the most common arrhythmia. In 5 years from now, it's expected to affect 12 million Americans. Why would a nephrologist talk about this topic? It's right seen here in the heat chart here that comes from the CKD Prognosis Consortium, where you can very clearly see that across both of the domains that we use to identify CKD, here lower eGFR and here increased ACR, or urine albumin to creatinine ratio, that the risk of incident atrial fibrillation increases independently across both of those domains, so that patients who have CKD G4 or A3 have approximately a threefold risk of experiencing incident atrial fibrillation than people who are in the white field with a GFR of 90 to 104 and negligible ACR. The highest risk, however, of atrial fibrillation exists in those patients with end-stage kidney disease, and it really depends how closely you look. If you run EKGs on all your dialysis patients in the metropolitan area of Vienna, where I grew up, 25% of patients had atrial fibrillation. And if you look even more closely and implant a loop recorder into those dialysis patients, and you look for 6 months, you will find almost half of those patients, 41% of those patients, had at least one episode of more than 6 minutes of continuous atrial fibrillation, which is clinically relevant and impactful. Now, I hope you pull out your phones. This is day 2 of the NKF, so you should be familiar with this already. So you have a patient that you visit in the dialysis unit. It's a 76-year-old woman who has diabetes, and she's on thrice-weekly hemodialysis and just got diagnosed with atrial fibrillation. We know, of course, that such patients with atrial fibrillation are at higher risk for ischemic stroke, depending on type of atrial fibrillation, 2.5 to 5-fold higher than otherwise similar patients who do not have atrial fibrillation. And this risk is especially high in the month after initial atrial fibrillation diagnosis. But the very same patients are also at increased risk for bleeding. What would you do? And you can read those options yourself. All right, we're good. We have 60, 70 responses. Can somebody take a picture of this? I want to take this home. Good stuff. So let's examine the evidence behind what you just decided you would do. So let's go back, a little bit in history, memory lane here, the efficacy and safety of vitamin K antagonists for stroke prevention and atrial fibrillation. And this is a pivotal meta-analysis of Bob Hart, who used all the placebo-controlled trials in the 80s and late 70s that compared warfarin to placebo, of course. And what he found was that this is really one of the most efficacious interventions that we know in modern medicine. Very, very rarely do you have a 62% risk reduction through an intervention. In this case, 60% reduction in ischemic strokes in those patients randomly assigned to warfarin compared to those who received the matching placebo. But what is forgotten, really, and hidden even in that paper is that not only does oral anticoagulation with warfarin reduce ischemic stroke, but it reduces all-cause mortality by not a small margin, by 26%. And that's important to keep in mind because that reduction cannot be simply explained by the reduction of strokes. And so what they concluded here in this meta-analysis, that adjusted dose warfarin reduced stroke by 62%. The absolute risk reductions were 2.7% per year for the primary prevention and 8.4% for secondary prevention. And of course, if you anticoagulate people, they are at increased risk of bleeding also. But as you can see here, major extracranial bleeding was increased by warfarin therapy with an absolute risk increase of 0.3% per year, which really pales in comparison to the very strong risk reduction that we see further up here. So clinically, this is a no-brainer. It's very strongly a favorable risk-benefit relationship here. And the guideline at the time, this was from 2012, patient without mechanical heart valves at high risk of stroke, chronic oral anticoagulant therapy with a vitamin K antagonist is recommended at a dose adjusted to achieve an INR of 2 to 3 unless contraindicated. Level of evidence A, we rarely get to see that in nephrology, although more frequently these days. And then the next recommendation specifies who exactly it is that we should anticoagulate. Now, as nephrologists, we need to ask ourselves, should these recommendations apply to persons with advanced CKD or even those with kidney failure on dialysis, specifically on hemodialysis? And why would we have these thoughts? Well, here's a pivotal paper by Steve Seliger a while ago, where he compared patients on hemodialysis to otherwise similar patients. They were matched on age and on sex and racial categories here. And as you can see, a patient with kidney failure on hemodialysis had a 4 to 10-fold increased risk of ischemic stroke. Really, these patients are at much higher risk. But unfortunately, also for hemorrhagic stroke, a very similar relationship exists in that patient on dialysis experiences a 4 to 7-fold increased risk of hemorrhagic stroke. And so that really comes also in the environment where we know that other bleeding complications are also very common, especially in patients on dialysis. For example, an almost 10-fold higher risk of non-variceal upper GI bleed. And then, of course, there's bleeding from vascular access. And so we need to ask 2 more questions. What are the relative incidences of thromboembolic versus hemorrhagic complications across the kidney function continuum? And does the severity of chronic kidney disease alter the benefit to risk assessment of oral anticoagulation? Well, we would like to rely on trial data, and the previous speaker had the benefit of having a wealth of trials to present. Not me today, sorry. But I have a little bit. So this is again Bob Hart, and he looked again at this wealth of his meta-analysis and restricted it to those patients, or restricted to those patients where GFR was measured, and then separated them into those who had a GFR of less than 60 or higher than 60. And as you can see here, with regard to the outcome ischemic stroke, in those patients who had relatively preserved kidney function, the risk reduction was 67%. And among those patients who had really mostly early stage 3 CKD, a 76 risk reduction. So magnitude very similar, each of those independently significant. All right, so we know, okay, that's good. We can reduce ischemic stroke even in those patients with relatively mild CKD 3B. With regard to bleeding, the confidence limits are all over the place. We cannot draw any conclusions here. So that's all of the randomized evidence here. And so when we're in such a situation, unfortunately, we need to rely on observation data. And there's actually plenty of very nice and very well-conducted observation work that supports the effectiveness up to CKD G4. Very little data beyond that. What about kidney failure on hemodialysis? There are only observation studies with regard to warfarin. This is a paper by Jenny Shen a decade ago where she used the USRDS and identified 13,000 patients newly diagnosed with atrial fibrillation who within 30 days from that index diagnosis either initiated warfarin or they did not. And then she did some geeky math, propensity scores and stuff. And I would like you to ignore the confidence limits for now. I'll get to that in the next slide. But look at the effect estimate. estimates. And from the effect estimates, you would think, yes, okay, maybe a 27% reduction with regard to ischemic stroke if you anticoagulate versus not. People bleed more when you anticoagulate them. And then there's this mortality finding, a 16% reduction in all-cause mortality, which here was even significant. But there are two important problems that we learned from this and the second study that we conducted at the time at Stanford. On the left-hand side, Felix Yang used the VA system and looked at patients who had atrial fibrillation and were anticoagulated with warfarin. And if you go for warfarin, you really want to keep people in this narrow therapeutic range between INR of 2 or 3. And what you can see here, and you see it on the horizontal axis on the left side, the most preserved kidney function, on the right-hand side, it goes down until dialysis, that the lower the kidney function, the less time do patients spend within the therapeutic range. And it goes all the way down here to dialysis patients who spend only 43% within the therapeutic range. Or in other words, they spend the majority of the time outside the therapeutic range, either being over-anticoagulated at increased risk for bleeding or under-coagulated, where they actually will not accrue any benefits. And then secondly here, that's from Jenny's paper here, those people who initiated warfarin, they didn't exactly stick with the therapy. Within 1 year, 70% were off warfarin. And so if you have a preventative intervention, can't keep people within the therapeutic range, and secondly, you can keep them on treatment, it's a relatively useless approach. So luckily, there was innovation at the time, and everybody was very excited about that. Warfarin being a very unspecific oral anticoagulant, we entered the era of NOACs, novel at that time. We call them DOACs now, direct target oral anticoagulants, which were approved starting in September 2010. All of them via non-inferiority trials compared to vitamin K antagonists. And of course, that's a DTI, the direct thrombin inhibitor, dabigatran, antifactor 10A inhibitors, rivaroxaban, apixaban, and edoxaban. All of these drugs, however, are either partially or even predominantly excreted by kidneys. All the trials, we know that, again, patient with advanced CKD and end-stage kidney disease not included, not permitted to participate in these trials. The FDA leaned their neck out and they approved labels for patients on hemodialysis based on very, very sparse evidence, specifically for apixaban and for rivaroxaban. And so for the effectiveness and safety in advanced CKD, we have a little bit of trial data, which I'll show you shortly, mostly in CKD stage G3B. And then for anything beyond that, worse kidney function, we again rely on observational data. Nice meta-analysis by Ziv Harel from Toronto, also 10 years ago already, where he meta-analyzed, again, these trials of vitamin K antagonists versus NOACs in patients who had a creatinine clearance of less than 50. It goes all the way down to 30, for dabigatran to 25, so it's CKD G3B mostly. And what you can see here is summarizing with regard to the outcome of stroke and systemic thromboembolism. You have a risk ratio of 0.84. The upper limit of the 95% confidence limit goes up to 1.04. Don't say non-significant. These were non-inferior trials, so you need to compare it with the benchmark non-inferiority margin, which in these trials was 1.25. We can conclude very safely that there's non-inferiority in those patients with CKD3B among these NOACs compared to vitamin K antagonists. What about safety? Very similar story. You need to look down here. Here the risk ratio was 0.89. The confidence limit went up to 1.16, so a little bit closer to any imaginary non-inferiority margin, but still you would conclude non-inferiority even for the bleeding outcome here. But interestingly, there's heterogeneity, right? You have rivaroxaban here, dabigatran, then you have apixaban, just the Aristotle trial here, which is an outlier here and which really indicates in terms of bleeding, it seems that apixaban is superior to vitamin K antagonism, to warfarin in terms of bleeding safety. And then again, we're looking at observation data, and at this point there's two, soon a third study coming out that compared DOACs with vitamin K antagonists. This is from a 100% Medicare CKD 4 and 5 sample by Edward Fu, just up the street from here. And let me just summarize, is the rate of ischemic stroke and mortality were no different between warfarin and apixaban. You can see the ischemic stroke hazard ratio of 1.14, the confidence limit spanned the null value, mortality 1.08, again confidence limit spanned the null value. But there was a clear signal with regard to increased bleeding events in patients in the warfarin category here, approximately twice the rates with warfarin compared to apixaban. What about kidney failure on hemodialysis? A propensity-matched analysis, and this asks the question again, no anticoagulation or anticoagulation using apixaban. Early data from the USRDS, Tom Mavrakanos, when he was at the Brigham at the time, looked at these data and really found not any major difference in the outcomes here. There were 522 new apixaban users that were matched with non-users, and the only thing that was found here was that there was an increased bleeding for those who initiated apixaban compared to those who did not initiate any anticoagulation, but all the other outcomes were not significantly different, and the confidence limits were very wide because these were sparse, very early data. We had the opportunity to update this very recently, and you'll hopefully read this in print sometime very soon. Same story here, and what we found here with many more patients, almost 4,000 new apixaban users compared to the same number of non-users. And with regard to ischemic stroke, the hazard ratio was 0.8. This was significant, also in the as-treated analysis. With regard to hemorrhagic outcomes, clinically important bleeding, 1.22, 1.18, significant, okay, more bleeding here. And then we have the all-cause mortality finding again, that those patients who were anticoagulated with apixaban compared to non-initiating oral anticoagulation had a mortality benefit here. We had some control outcomes that couldn't plausibly be related to the exposures here, and those are expected to be very close to the null value, and that turned out to be the case, which makes it a little bit more confident here, despite it being observational, that these were reasonably balanced cohorts in the two exposures groups. Of course, we would like to see trials, and indeed trials were attempted to compare apixaban with warfarin. There's no placebo group here, so this is apixaban versus warfarin, both of them non-inferiority trials with regard to safety, with regard to bleeding safety. The first one, the Renal AF trial, US-based, apixaban was dosed at 5 milligrams unless a dose reduction per label was indicated. The other one was in Germany, 2.5 milligram apixaban for everybody. Without any further ado, these trials failed to enroll. In Renal AF, we were hoping to get 800 patients. We doubled the enrollment period. It didn't help. We enrolled 154 patients. For a non-inferiority trial, it's the kiss of death. And the same thing happened down here with the German trial. So we can really not conclude anything from these trials other than the pharmacodynamic and pharmacokinetic studies that were done in Renal AF that really confirms the dose recommendation by the FDA that in patients on dialysis, a full 5 milligrams BID dose is appropriate, unless you need to reduce because patients are either too old or they're underweight. Observation data again. Very nice paper by Konstantinos Siontis from the Mayo Clinic at the time. Why do I show this? Especially because they looked at the different dose exposures. Warfarin is the reference group here. Apixaban is the comparison group. Apixaban 2.5 milligrams in black, 5 milligrams BID in orange, very fitting for this conference. And as you can see here very clearly, that there was really no reduction in stroke in those patients who were initiated on apixaban 2.5 milligrams compared to warfarin, but there was a significant protective effect or association, I should say, those who have received apixaban 5 milligrams BID. Again, same story here. For death, no prevention whatsoever, but patients who received apixaban had a mortality benefit compared to those who received warfarin. Again, restricted to those who initiated apixaban 5 milligrams BID. What do the guidelines say? And these are the more recent guidelines. I apologize, the citation didn't come through here. This is from the most recent AHA guideline. With regard to patients with atrial fibrillation at elevated risk for stroke and who have end-stage CKD, that's really CKD5 or CKD5 on dialysis, it might be reasonable to prescribe warfarin to an INR of 2 to 3 or an evidence-based dose of apixaban for oral anticoagulation to reduce the risk of stroke. Here's Winkelmeyer's take on this. Unsolicited, this is not a guideline, this is opinion. I give it a conditional yay on oral anticoagulation depending on who the patient is and using what agent. I would not initiate anticoagulation in persons with very low risk of stroke, but I would like to put out the caveat, I don't think in the very advanced CKD or dialysis population many such patients exist. These patients are at high risk of stroke. I would also not initiate anticoagulation in persons who had a very high risk of stroke. I didn't talk much about these scores, but I'm sure you've heard about the CHAD score and the CHAD-SVAS score. If they have a score of 7, 8, or 9, these patients have one-year mortalities of 37, 50, and 63%. Remember, this is a preventative therapy. These guys have a very high mortality. You might not make a difference by anticoagulating them. But I would very much consider anticoagulating persons in the intermediate range of risk following a shared decision-making process in those who have a CHA2DS2-VASc of maybe 2 to 6. In my opinion here, I disagree with the AHA guidelines. It's not reasonable to use warfarin unless apixaban is not indicated. And I personally would use the full dose apixaban 5 milligram dose BID unless the dose reduction is indicated per label. And people are voting with their feet. This paper that we very recently published where we looked at the USRDS. And for a very, very long time, approximately 20% of patients received oral anticoagulation at the time only warfarin was available within 30 days of being diagnosed with atrial fibrillation. But once the FDA approved the label for apixaban dosing, people started using this drug. And you can see here almost twice as many patients nowadays are being initiated on apixaban shortly after being diagnosed with atrial fibrillation, and the vast majority receive apixaban. So you guys got it right during the polling question early on. Let's switch gears here, looking into the future a little bit, doing okay on time. There's a new category of drugs coming out down the pipeline. Or they're trying to come down the pipeline, let's put it this way, and these are factor 11 and factor 11A inhibitors. Now, it's always dangerous when a nephrologist tries to explain the coagulation cascade, but I have to here. All right, you remember there's the intrinsic and there's the extrinsic pathway, right? And where's our factor 11? Our factor 11 is over here. It's at the contact activation intrinsic pathway. And so what happens in this case when you interrupt this? The extrinsic pathway is not interrupted. People can still initiate and go down the coagulation cascade, no problem. And that's usually when you have, when you have a wound or you have an accident, motor vehicle accident, gunshot wound. I come from Houston after all. Working at the county hospital. And then, however, on the when you go here over to the contact activation, think dialysis filter, think, tubing. That side here is interrupted. So maybe there's something in it for our patients. And there's very interesting, both natural and experimental evidence this might be a good proposition. There's a natural model, and that's called hemophilia C. Hemophilia C is a misnomer. It's not a hemophilia, actually. These patients are lacking factor 11, heterozygous or homozygous. Homozygous, almost no levels of this factor. Heterozygous, usually around 50% level of factor 11. And what we know from cohort studies of patients with hemophilia C, they have a much reduced risk of stroke and of venous thromboembolism, also of heart attacks. However, they also have a minimal increase of bleeding. And that bleeding occurs in these patients with very specific surgeries. Tonsillectomy, I gave this talk somewhere at the ACI, I think, and somebody walked after me afterwards, and I have this condition. I almost died when I had a tonsillectomy as a 5-year-old. That's how they found out at the time. Sinus operations, urogenital surgeries, but no problem with any other major surgeries, interestingly. And all of this is also supported in a number of animal models. So the value proposition of intervening on factor 11 is really to uncouple the thromboprotection from the increased bleeding risk. And this by now has been well demonstrated in phase 2 trials that use knee replacement surgery and look at radiologically defined deep venous thrombosis. That's the gold standard in the hemophilia and then coagulation world to see whether something works or not. And so now this is being tested in other indications and may even go towards more general cardiovascular prevention. Of course, all these drugs, I've been reminded to let you know, these are not approved drugs, right? These are all under INDs and not currently FDA approved for clinical use. And so here are some of these phase 2 trials with the knee replacement studies, all of them in pretty decent journals. And there was even two actually at this point who were also published, looking at atrial fibrillation patients, phase 2, the Pacific AF, which was run at the Duke Clinical Research Institute, Jonathan Puccini, and another one. And so those have now gone into phase 3 trials. And so we have oral agents here. This is asundexian. The other one is milvexian. These are daily oral treatments. This one was very interesting. Died a very sudden death when during an interim analysis was found that this comparison of asundexian versus apixaban, that asundexian was inferior in terms of stroke prevention compared to apixaban. So this study was killed very, very quickly and very sadly with it a companion trial, the Oceanic Athena trial, which was supposed to enroll 300 patients on hemodialysis. So I was very sad to see that somebody wanted to invest into a trial in our populations, and then that went away. All right, the other one is very similar in design, milvexian versus apixaban, and that one is still ongoing. It's fully enrolled, and we can expect the results, I think, in the end of 2027. And there's another trial that's of relevance to us, and that's the LILAC trial. This is a different mechanism. This is also a factor 11 and factor 11A combined inhibitor. It's an antibody. And it is abelacimab called. It's given subcutaneously monthly. And this is a placebo-controlled trial. So they took a different approach here. They didn't do a non-inferiority trial compared to another NOAC, to apixaban or something, but rather to placebo. And they were able to do so ethically because they enrolled patients whom their physician considered not being suitable candidates for oral anticoagulation, right? But they had to be at high risk, and there were 4 high-risk conditions that made people eligible for enrollment, and one of those was severe renal insufficiency. They didn't use the K word. Okay, so I mean, there is hopefully something coming our way. These results will come out probably at the end of next year, and we're crossing our fingers. Maybe something good is coming from this. And interestingly, there was also interest on exploring the safety and then the efficacy of these agents or similar agents in patients on hemodialysis. And so there were several trials using different agents. There's fesomersen, there's osocimab. These trials have been published. Phase 2 small trials, 308, 704 patients here. Mainly interested in looking at bleeding risk in these patients, and then also trying to find out how we can enroll these patients and ascertain a very broad cardiovascular endpoint, practice the adjudication, et cetera, et cetera. And then there's a third trial with a Merck agent, MK-2060. If you want to see those results, I'll not show you them. You will need to travel to Vienna in June, where we'll present this as a late breaker. And I can tell you the results today. But those other 2, fesomersen and osocimab, have been published. I'm not going into great detail here, but I'm summarizing these findings for you. All of these agents are very capable of reducing factor 11 or factor 11A levels in activity very reliably down to a level of like 10 or 20% of original activity. In both of these trials, there was no signal whatsoever towards increased bleeding compared with a placebo group. However, there were very few cardiovascular events. In the fesomersen trial of those 300 patients with 4 cardiovascular events, clearly indicating that a very healthy hemodialysis population was enrolled in this trial. But one thing that was interesting from those 2 trials, there was a signal towards less dialysis circuit clotting in those patients who were randomized to osocimab or to fesomersen compared to those in placebo. So we'll see. I hope that in the short period of time that we spent together, I was able to convince you that atrial fibrillation is common, and it's consequential in the end-stage kidney disease population as well as those with advanced chronic kidney disease. Exclusion from these pivotal trials generates uncertainty whether the net benefits of oral anticoagulation extend to patients with advanced CKD or end-stage kidney disease. Observation data, despite it being my bread and butter, are limited by off-label practice and residual confounding by indication, but sometimes it's the best evidence that we get. Something's promising here, and that's the very brisk enrollment that we've seen in these factor 11, factor 11A phase 2B trials, and also the encouraging safety results that we've seen to date in those 2 trials that I just mentioned. And so I really want to close with the hope that this paradigm of factor 11, factor 11A inhibition may be safe and hopefully efficacious in patients with advanced CKD or with those on dialysis in whom a very big unmet need exists, in my opinion. So thank you very much for listening to me, and I thank
you. All right, we definitely have a time for 1 or 2 questions.
Thank you very much. Very elegant presentation. In your personal opinion recommendation that you put at the end, you suggested to give Avexapan 5 milligrams twice a day unless the label suggests something different. And the label suggests something different. All the labels suggest to reduce the dose into half, 5 milligrams a day or 2.5 milligrams twice a day, half the dose. So what you're suggesting is just 2 different things. give 5 twice a day, and the label say half the dose. So which one should we go by?
Yeah, the label doesn't say half the dose. The label says half the dose if 2 of 3 conditions are met. One is advanced chronic kidney disease, which is met in all of these
I'm talking
patients.
about end-stage renal disease.
The second one is age over 75, I believe, and the other condition is a body weight under 60 kilos, I think. Yeah. So you're right. There approximately a quarter of these patients require a reduced dose per label, but 3/4 of our dialysis patients do not.
We'll take the full dose if they, if they don't meet the age or the weight.
5 milligrams BID.
Excellent. All right. Thank you, Dr. Winkelmeyer. So we will move on. So our final speaker is Dr. Suzanne Nicholas. She's going to talk about the newly introduced concept of cardio-kidney metabolic syndrome. What is the nephrologist role? Dr. Nicholas is professor of medicine and hypertension specialist at the David Geffen School of Medicine at UCLA. She chairs the UCLA Division of Nephrology, Racial and Health Equity Committee. Dr. Nicholas.
Well, good afternoon, everyone. It's really a pleasure for me to talk with you today about this very interesting topic. And as you've heard from the first speaker, Dr. Edmonton, we're at a wonderful time within the cardio-kidney metabolic space. But we've got these new therapies now that have multiple benefits in patients that can provide us with an amazing opportunity to improve clinical outcomes for our patients. But what we really need is a strategy or a tool that can help us to coordinate the care for these patients. And what I'm going to offer to you today is food for thought of how the nephrologist and nephrology community can actually step up to improve clinical outcomes for our patients. So these are my disclosures, and there's no branded information in this talk today. The objectives, what I'd like to do is to start off with reviewing the definition, the risks, and staging of the cardio-kidney metabolic or CKM syndrome, and then review the burden of CKM syndrome, followed by discussing the interrelatedness of the CKM components. And the rest of the talk will be on discussions of how the role of nephrology in the management of CKM syndrome. So what is CKM syndrome? It's not cardiorenal syndrome. It's not CRS, where you've got just that bidirectional interplay between the kidney and the heart. CKM is really a systemic disorder that involves metabolic risk factors, chronic kidney disease, and the cardiovascular system. That includes those individuals who are at risk for cardiovascular disease, as well as those who have existing cardiovascular disease. And that contributes to the increased likelihood of these individuals developing CKM syndrome, which unfortunately is associated with very adverse outcomes. And these adverse outcomes can be influenced by a number of factors that are unfavorable in terms of conditions for lifestyle and self-care that result from policies, economics, and the environment. And it's under the term that we're familiar with called social determinants of health. And we'll talk a little bit about that next. So looking at this pictorially then, right, we could look at the CKM syndrome and look at the interrelatedness of health disorders and shared risk factors that include hypertension, obesity, and it's actually called excess adiposity or dysfunctional adiposity. It's a new term. We'll talk about that in a second. Dyslipidemia and type 2 diabetes that all contribute to dysfunction and leading to chronic kidney disease, cardiovascular disease, and metabolic syndrome that can all increase the risk of morbidity and mortality. And as such, we really need to have a clear understanding of what the CKM syndrome is, the interrelatedness of the components of the CKM syndrome, so that we can really coordinate the screening and the monitoring and management of our patients so that we can reduce morbidity and mortality. So it turns out that there are some unique risk factors that are associated with CKM syndrome. And these include, and I don't think you'd be too surprised, insulin resistance in the metabolic syndrome, atherosclerosis, heart failure, sedentary lifestyle, chronic inflammation and endothelial dysfunction, and early life exposures, which some of these risk factors in early life may be undetected. And so there's the consideration that maybe we need to start screening early in life, under age 21, for example. We need to screen for metabolic risk factors and chronic kidney disease in adults, and also look at subclinical cardiovascular diagnosis and screen for social determinants of health. And I'm sure within this audience that there's an increased awareness of the social determinants of health. And when we talk about that, we're really talking about things like economic stability that encompass the individual's income, their employment, their financial stability, access to quality education, access to affordable and quality health care, access to safe housing, healthy foods, green spaces, and transportation, as well as social support network and community resources. And you can imagine, if you think about these items that fall under social determinants of health, that they can in fact impact the way that the patient receives care and ultimately impact their clinical outcomes. So let's look at the pathophysiology of the CKM syndrome. I mentioned to you this term excess or dysfunctional adipose tissue or adiposity. And it turns out that our adipose cells, really they're supposed to be providing energy. But within the CKM syndrome, these adipose cells actually produce pro-inflammatory cytokines and pro-oxidative products that then lead to ectopic fat deposition, particularly visceral fat. And then this, with the production of metabolic dysfunction associated liver disease, potentiates factors that lead to chronic inflammation, oxidative stress, insulin resistance, and vascular dysfunction. And with this being sort of central to what happens outside of that, you get the development of the metabolic syndrome with hypertension, dyslipidemia, and diabetes. And on the other hand, you've got impact on the kidneys leading to glomerulosclerosis, tubular interstitial fibrosis, and chronic kidney disease. There's also impact on the heart, where there's atherosclerosis, myocardial modeling, fibrosis, and cardiac dysfunction. And the cardiorenal syndrome that I mentioned earlier is that interplay, that bidirectional interplay just between the kidney and the heart. But with CKM, now you've got the inclusion of metabolic syndrome. There's also actually neurohormonal excitation, and this really refers to chronic activation of the renin-angiotensin system as well as the sympathetic nervous system that can have an impact to produce increased portal hypertension and volume overload or ascites. So with that as a background, let's talk about CKM syndrome staging and the definitions. And some of you, I'm sure, have heard of the stages of CKM that are staged between stage 0 to stage 4. And we'll go through each one of these. So for stage 0, this is where an individual has no CKM risk factors. So for example, they've got a normal BMI, normal waist circumference, normal glycemic levels, their blood pressure is normal, they've got normal lipid profiles, and there's no evidence of chronic kidney disease or cardiovascular disease. On the other hand, as the individual may progress over time, they may develop excess or dysfunctional adiposity. And this is represented by, there we go. Or being overweight or obesity, having abdominal obesity, and dysfunctional adiposity with BMIs that is at least 25 or greater, waist circumference measurements that are at least 88 or greater centimeters in women, 102 in men, or without any other metabolic risk factors. So their fasting blood glucose is between 100 to 124. The A1C measurements are within pretty good limits of 5.7 to 6.4, and there's no evidence of chronic kidney disease. So moving on now to stage 2 CKM. This is where there's metabolic risk factors and or the presence of chronic kidney disease. And this is marked by hypertriglyceridemia, hypertension, metabolic syndrome, diabetes, as well as possibly chronic kidney disease. In the more advanced stage of CKM at stage 3, there's now subclinical cardiovascular disease. And this is marked by subclinical atherosclerotic cardiovascular disease or subclinical heart failure, increased cardiovascular disease biomarkers, or the individual may be symptomatic, or some of these illnesses may be, disorders may be detectable, including atherosclerosis and arterial stiffness. And then the most advanced stage of CKM is the clinical cardiovascular disease is present. And this stage is divided further into stage 4A and 4B. 4A is in the absence of kidney failure, whereas 4B is in the presence of kidney failure. And this can have, at this point, the individual has clinical evidence of cardiovascular disease marked by coronary heart disease, stroke, heart failure, and arrhythmias. We heard about a couple of these the last 2 talks, so we're pretty knowledgeable right now about this. So what about the global burden of CKM? It turns out that this is quite substantial. And looking at the different components of CKM, we know that there are about 700 million individuals with chronic kidney disease. Unfortunately, about 90% of these individuals don't know that they have chronic kidney disease, in part due to underdiagnosis. It's something that the nephrologist can change, I believe. Where cardiovascular disease is concerned, there are about 523 million individuals living with cardiovascular disease. And when it comes to diabetes, about 537 million between the ages of 20 to 79 that have diabetes, and this is an older estimate. Data from the global burden of disease indicates that ischemic heart disease and stroke were actually the major contributors to the CKM syndrome, with the largest burden being in places in Southeast Asia, as well as the Western Pacific. And this same data from 2021, looking at data between 1990 and 2021, they estimated the disability-adjusted life years, or DALYs, for 7 of the components of the CKM syndrome. And they found that it's increasing due to both population growth as well as our aging population. As you can see, the color coding here for aging is in red, and for the growth in the population is in orange. And then the components of CKM that were examined were high BMI, and for high BMI, they're referring to BMI of greater than 23 kilograms per meter squared, diabetes mellitus, chronic kidney disease, atrial fibrillation and atrial flutter, lower extremity peripheral arterial disease, ischemic heart disease, and stroke. And in this data, they also looked at trends for stroke, peripheral arterial disease, and ischemic heart disease, and it seems as though there may be a declining trend for these 3 entities. However, high BMI and diabetes have an increasing trend. As you can see here, high BMI is in the light blue, and diabetes is in the dark blue. So there seems to be an increasing trend between 1990 and 2020. Looking at the burden of CKM syndrome within the United States, and this is data that was not too long ago published, last year, in fact, by Agarwal in JAMA 2024, and they commented that CKM syndrome affects more than 25% of the US adults, and this is data taken from between 2015 and 2020. And it was the leading cause of death, actually, in 2021. They also looked at temporal trends of CKM within the US, and they obtained data from NHANES between 2011 and 2020. As you can see from the graph, that you have the highest prevalence of CKM2, which is in the blue at the very top, followed by CKM1, and then the other CKM stages, and some of the data are shown here on this slide. What's also important to know is that individuals who are 65 years and older were more likely to have more advanced stages compared to younger individuals between 45 to 64 years. And the highest prevalence was in the CKM 2 and 3, as you can see. So for the rest of the talk, I want to describe to you the possible roles of nephrology in managing CKM, or cardio-kidney metabolic syndrome. And as you can imagine, that there are potentially several. And this is just, I would think, I hope you agree, an abbreviated list, right? I'm sure you could probably think of several other areas where nephrologists and the nephrology community can actually play an important role. But the ones that I've listed here are in risk stratification. So nephrologists can assist with early chronic kidney disease screening. We already know that a large proportion of individuals with CKD aren't aware of their diagnosis. So we can assist with CKD detection, particularly individuals who are at risk for CKM. We can assist with disease monitoring, tracking CKD, as well as CKM progression over time. We can assist with medication management, not only with initiating therapy, but coordinating the initiation of therapy with the patient's care team. We can assist with acute interventions. We've heard that one of the complications really is volume overload, and so nephrologists are really good at managing that, and we can certainly play an important role there. And then multi-specialty coordination, where we can bridge care across cardiology, endocrinology, and primary care. We can empower patients by educating them on different aspects related to their disease progression, as well as be involved in system-level leadership. So I want to take each one of these and discuss them in a little bit more detail. We've already talked about the unique risk factors for CKM syndrome, but it turns out that there are a number of risk factors between CKD and CKM that overlap. That include, and I'm sure that you're not surprised about this, diabetes mellitus, hypertension, obesity, smoking, dyslipidemia, a family history of kidney or heart disease, older age, older than 60, that becomes closer to me as every time I talk about it. Ethnic minority groups, particularly African American, American Indians, and South Asian individuals, and those from low socioeconomic status. So I'm going to show you something that you're very familiar with, right? We've already seen this in the previous talk, the KDIGO heat map, right? We're very familiar with this. My perspective is that we really don't use this as often as we really need to, not just for the work that we do, but to discuss CKD with our collaborators and especially with patients. So the CKD heat map allows us to classify chronic kidney disease, but it also allows us to risk stratify for chronic kidney disease progression, and it turns out also cardiovascular disease progression. So we know that there are 5 stages of CKD based on the eGFR measurements, as well as the concomitant albuminuria categories, anywhere from with A1, A2, and A3, between less than 30 to greater than 300. And anyone who sits within the green area of this grid will be at low risk for CKD progression, cardiovascular disease. And if you sit within the yellow parts of the grid, you're at moderate risk. For those in the orange parts of the grid, they would be at a high risk, and in the red zones, at very high risk. So one of the things that I always want to talk about is the fact that UACR and eGFR is each an independent predictor of cardiovascular mortality. We've already heard, and we're very familiar, that most of our patients actually succumb to death even before they get to kidney failure. But when we look at UACR, even within the normal range, and I was really pleased to see Dr. Winkelmeyer's slide that actually included that. And you can see here at an eGFR that's less than 30, there's already an increased, the hazard ratio for cardiovascular mortality is already increased. So we don't really think about that, right? But I think it's becoming more evident and something to consider with the CKM syndrome. And an EGFR of 60 and lower, again, the hazard ratio for cardiovascular disease mortality increases. And this data was taken from the CKD Prognosis Consortium. I really hope that you will all remember this and communicate this to all of our colleagues. One of the reasons is because we already know that measurement of UACR is extremely low, it's about 20%, right, across the country. For some areas, maybe at the VA, it's probably about 50%. I'm sure that you can corroborate that. But overall, it's actually pretty low. And that in of itself is an independent predictor of cardiovascular mortality. So we really need to know these numbers. And essentially, a UACR of 10 or higher milligrams per gram and an EGFR less than 60 are significantly associated with increased cardiovascular mortality, independent of each other, and as well as independent of other traditional risk factors. So I've been playing around with this, trying to make it easy for us to really assimilate this information, to understand it, and to be able to communicate it to our colleagues. So what I'm trying to do here, and you can go home and you can test it yourself and let me know, is I've got the KDIGO heat map, and I've got the stages of CKM from stage 1 to stage 4. And at the bottom of each, as you can see, is the level of risk that I can now transpose or align with the KDIGO heat map. So for stage 1, where there's some metabolic risk, but because of excess dysfunctional adiposity, individual can be at low to moderate risk, so that the EGFR is probably about 60 or greater, and they're in the A1 UACR category. For an individual, I think I have a pointer. For an individual in CKD stage 2, where there's early organ dysfunction, the individual can be at moderate to high risk, and the EGFR is between 45 and 89, and they're in the A2 category. For those in CKM stage 3, where there's subclinical cardiovascular disease, they would then be at moderate to severe CKD, and cardiovascular risk is anywhere between high to very high. And the EGFR would be around 30 to 44. And then finally, in the most advanced stage of CKM, stage 4, where there's clinical cardiovascular disease and possibly end-stage kidney failure, the individual may be at highest risk. So I then now took that and I placed it onto the KDIGO's heat map. And this is what I obtained. So you could see in the green area where you have CKM, individuals at low to moderate risk, CKM2, where they're at moderate to high risk, CKM3, where they're at high to very high risk, and CKM4, where they're at high risk. And there may be some overlap between CKD3 and CKM3 and CKM4. But I think this really, it brings it together, and it simplifies it in a manner that is, I think, easily digestible. So we can use this as a tool for not only monitoring, but also for initiating therapy, and as an opportunity to discuss CKM with our colleagues and also with patients. And this you're also familiar with, right? The KDIGO heat map, we can use this to monitor EGFR and UACR, and it tells you when to screen and how often clinic visits should be for an individual depending on their severity of CKD based on the EGFR and UACR. When it comes to CKM, regular EGFR and UACR monitoring will depend obviously on the severity of CKM. And this is an example here for CKM0, probably need to monitor patients every 3 to 5 years. And as they progress across the CKM stages, monitoring would be certainly more frequent. Now let's talk about medication management. And as I mentioned, the nephrologist can play a very important role in initiating these cardiorenal protective therapies. And we're familiar with the 4 pillars. You've heard about these on top of lifestyle modification. I'm not going to go into each of the clinical trials that support this, but this is a table that really summarizes all of the data and from clinical trials for the 4 pillars. and you will have access to these slides. And then this summarizes further guidance for the use of the GDMTs. And I know that many of us are very familiar with, but it really gives you the thresholds for EGFR as well as UACR, the indications and additional notes here. So what I've done now is to summarize indications for GDMTs in both CKD and CKM syndrome in terms of what they can accomplish, some examples within each class. So for the RAS inhibitors, to improve intraglomerular pressure, proteinuria, as well as some cardiovascular benefits. And for the SGLT2 inhibitors, to improve glucose control, kidney protection, as well as cardiovascular benefits. For finerenone, to decrease inflammation, fibrosis, and albuminuria with cardiovascular benefits. And then finally, semaglutide, or GLP-1 receptor agonist, for primarily glucose control and weight loss with additional cardiovascular benefits. But the question comes up is, how well are we actually using these therapies? We looked at this a couple of years ago, within our Cure CKD registry. So UCLA Health and Providence Health have collaborated about 10 years ago now to create a very large chronic kidney disease registry. And we looked into the registry between 2019 and 2020 to identify prescriptions for guideline-directed medical therapies. And we wanted to follow patients over 90 days and beyond to look at persistence of use of these therapies. So I'm not going to go into detail because I'm kind of getting short on time, but essentially there were over 39,000 individuals that fit the criteria for having chronic kidney disease and diabetes, up to an EGFR of 15. And this is the data that we obtained at baseline and then 90 days later. And what you see for ACE and ARBs, that about 71% of prescriptions were for ACE and ARBs, right? After 90 days, it dropped to 40%. That's very telling, right? Because it tells you that individuals, maybe they're hospitalized, they develop AKI, their medications are discontinued, they're not reinstated. But I think that's something that we certainly can do a much better job on. We also looked at the prescriptions for the guideline-directed medical therapies, and granted, this was very early on, so the uptake was rather on the low side, but again, also very telling. As you can see, prescriptions for SGLT2 inhibitors, GLP-1 receptor agonists, and the MRAs was between 5 and 9 or 10 at baseline, but there was a significant reduction 90 days later. Imagine if we fast forward to today, where hopefully the uptake is a little bit better. You know, how well are we doing? I would love to be able to redo this study. One of the interesting things that came out of this study is, what happened? I'm sorry. One of the interesting things that came out of the study is the use of NSAIDs and PPIs. Look at the prescriptions, right? I know we're laughing. Anyway, I don't need to say more. So looking at, we certainly, nephrologists can assist with acute interventions, particularly when it comes to volume overload. I'm going to go through this very quickly. To assess and manage AKI, to prevent contrast-induced nephropathy, and to manage volume overload, and to coordinate and collaborate with cardiology and the rest of the patient care team to manage both systems, and to adjust the RAS inhibitors in CKD patients to balance the benefits and risk, and then, of course, to manage electrolytes. We heard about hypokalemia that can happen in patients who are on finerenone, and so this is something that we certainly can assist with, and to initiate dialysis whenever that's needed. And when it comes to multi-specialty coordination, I think nephrologists have a very important role to advance this significantly. We did a systematic literature review of studies out there that were involved in coordinated care programs to assess, their efficacy. And we identified there were over 1,500 publications, but out of those, there were 22 that we actually were able to assess their interventions. We identified 8 with randomized controlled trials, 13 observational trials, and there was one other that was combined. Most of these studies were published in the United States, as you can see, followed by the United Kingdom. And the types of interventions were divided amongst multidisciplinary team. Most of the programs were multidisciplinary team. Those that were involved, that involved patient engagement and education, There were 5 that had pharmacist integration, and actually one of the studies we had done previously was part of this. And then 2 studies included multidisciplinary team as well as multi-specialty team. And we assessed their clinical effectiveness, cost effectiveness, as well as healthcare resource utilization. And the results were that there was, and I'm sure you can imagine, right? It would be positive, as it should be, right? There's greater participation, patient satisfaction with coordinated care programs compared to usual care. There was decreased healthcare costs with further reductions for use of telehealth. There was also a decreased number of health-related problems and increased attendance rates for virtual consultations. But there were some challenges, as you can imagine. I'm just going to list them here. There were challenges in gaining consensus among interested parties regarding program protocols and management approaches, as well as confirming the accuracy and completeness of patient self-reports. Some programs had some IT problems due to system complexity or maybe the lack of access to appropriate IT equipment. And then there were patient difficulties attending clinics, maybe they didn't have transportation, et cetera. And non-attendance rates for return visits was actually top there. So from this study, you concluded that there's a diverse set of coordinated care approaches for delivering CKM care, that coordinated care is effective in improving patient care and in reducing healthcare costs. And there's widespread use of multidisciplinary teams and telehealth in clinical settings, which would benefit patients with CKM. And we really need more standard reporting of coordinated care interventions to assess the beneficial components of a program and its overall effectiveness. I don't think I'm going to have time to go through this study. Maybe in the Q&A, I can go over the cinema. For those of you who might be familiar with this is really, I think, an example of a coordinated care patient-centered approach that nephrologists can really take advantage of. But I would just show you the results of this. Significant increase in SGLT2 inhibitor use, almost doubled, more than doubled. Increased GLP-1 receptor agonist use as well as there was reduction in many of the risk factors for CKM. And then the final couple of slides, patient empowerment, things that we can do to educate not just our colleagues with patients on lifestyle, to discuss prognosis with the patient, and to explain treatment options. We probably don't do as good a job of that as we need. And then finally, nephrologists can play a very important role in system-level leadership, to advocate for supportive care policies, to conduct and promote research in CKM. It turns out that there are several gaps that still exist within the CKM space that we really still need to do research on, and some of these are listed here. And then to advance access and equity in CKM. So this is my summary slide. I just want to go through this very quickly, that CKM syndrome is a systemic disorder. It involves metabolic risk factors, chronic kidney disease, as well as the cardiovascular system. There are unique CKM risk factors. When it comes to the pathophysiology of CKM syndrome, dysfunctional adiposity is where it begins. The nephrology community can indeed play a significant role in CKM management, engaging in many of these activities. And with that, I'd like to say thank you.
Thank you. So I know we're out of time, so we have many questions in the Slido. We will request the speakers to answer those questions if possible in the Slido after the session. Thank you so much. This concludes the session. Thank you all speakers for an excellent presentation.